Hello everybody, my name is Georg. I'm on my couch in Freiburg, Germany, and on his couch in London, Ontario is my good friend and colleague Richard Rosedale. Hello Richard.
Hello Georg, hi everybody.
Yes, our topic today is a hot one, and it is, do anatomy and pathology matter? So Richard, what's your take on this? Easy question, isn't it?
It is an easy question, but I think first of all it's interesting to see where a question like that comes from, and I think that our focus a lot of the time is to kind of try to sort of pull people away from just that focus on anatomy and pathology and try to sort of get them to think about the symptomatic and mechanical responses in order to classify their patients. However, in doing so, I think it can give the impression that we don't care about anatomy and pathology, or we don't think it's important.
You mean we as McKenzie folks?
Yeah, that's right. I think it can give that impression, and people then say, well, it is important for this reason or whatever, and I think actually we also feel it's important for various reasons.
But isn't McKenzie famous for making non-anatomical, non-pathological diagnoses?
Yes, of course, but that doesn't mean to say that a knowledge and insight into anatomy and pathology is not important. I think it's a background that we all need in order to be, not just sort of effective clinicians, but safe clinicians as well. I think, the first thing that comes to mind with that is more of a safety issue in terms of that knowledge of structure and function and anatomy. And I think the example that always comes to mind is, if you have a patient with rheumatoid arthritis, and even early on in rheumatoid arthritis, we all know that the transverse ligament can be affected, and that can obviously the dens is less restrained. So with movements like flexion extension, especially with flexion, then obviously this could be a problem in terms of the spinal cord. So our knowledge of how that the mechanics of the cervical spine when it moves in relation to the dens is an example of why, it's certainly good to know that. And even you could argue, well, symptomatic response would tell us if somebody got the cord compression signs, we would stop doing what we're doing. But even so, it tells us that we need to be cautious with certain movements in certain conditions. So that's one example. And I know you talked earlier about another example where that knowledge is important.
Yeah, if you think about our classification system and classifications like stenosis, canal stenosis, neuroforaminal stenosis, or the mechanical unresponsive auricular syndrome, we talk about structures, we talk about the nerve root, and we see that these structures they have some importance. It does not necessarily mean that we already know what to do, just knowing about the structure that's involved, but we certainly appreciate and we know that there is a structure behind that, and there is some kind of pathology based on anatomical findings. Sure.
So the example, when we talk about a classification of structurally compromised, we're thinking about the structure. We must have some knowledge about the structure in order to sort of speculate what that structure is. And
yes,
I think the other thing is it makes us aware of our limitations in terms of what we do. If we don't have that knowledge, I think maybe we can think we can do all sorts of things that is actually unrealistic in terms of the knowledge of anatomy and pathology. And I think you talked about contractile dysfunction and tendinopathy and what we can and can't achieve.
Yeah, so contractile dysfunction, actually if you look at our system, that's kind of a compromise, because we talk about the contractile dysfunction syndrome / tendinopathy. So we have the derangement syndrome, where we don't care about anatomy and pathology. We say that's a clinical phenomenon. But when it comes to contractile dysfunction, we kind of adapt the knowledge we have from the research about the changes in tendons, and so we know about that, and we treat tendons. But nowadays we don't think anymore that we can remodel them, because we know from research that also a patient can get much better function, less pain, all good, but there might be no changes at all in the tendon. So it's not necessary to achieve structural changes. And that shows us, as you said, the limitation on how can we really influence structures, but we can improve the loading capacity of that tendon or just improve the function of this patient. So structure is important, but
I think that's a good example of where we've kind of, with a knowledge of the research as it's come along over the decades, where we've actually changed our kind of terminology and our focus, talking about, yes, we can change this tendon and realign all the collagen nicely so it's lovely and pristine again when we load it, and now we know that's.
So actually, do you think that clinicians, they want anatomical diagnosis? They are really interested in pathological findings or pathology? Does it matter in this extent, or to this extent, in this population?
Yeah, I mean, I think because of our training, many of us still are sort of after that anatomical sort of and pathology explanation. I think, many people now have kind of made that shift away, but I think underneath sometimes, everyone kind of reverts to that and they're all after that. And I think maybe that what comes along with that is the assumption that, the patient wants that kind of anatomical pathology kind of detail. And so the question is, what do patients feel about this? Do they need that information or that detail?
I think there is some research on this. What do patients expect from a clinician? What do they expect from physical therapy or other clinicians? And amongst their expectation, there is diagnosis. They want to have a diagnosis. But I love the paper by Camper, because they write, I don't know if it's on purpose, they write diagnosis or explanation of their problem. They don't talk about an anatomical diagnosis. They don't talk about give them a structure or a pathology. They talk about explanation.
I think I don't think we have that detail to know what it is exactly that the patient. I think every patient, it seems a good chunk of patients, wants that explanation and diagnosis, if you like. But I don't think we really know the details of what type of information they want. And that may vary, of course, depending on the patient. And it's interesting that, in that study, it talks about, I think the McRae study, it talked about education level being related to that as well. And almost sort of the higher the education level, the less someone is really concerned about the diagnosis. So depending on the patient in front of you, I think, and your conversation with them will depend on, sort of how much detail you need to get into. And, with many patients, do you really need to get into that anatomical and pathology?
Yeah, and that's also, I think it's from the McRae paper, where they found that 2/3 of the patients, they found extremely important to have a pain reduction and an improvement in function, but only 1/3 they found it extremely important to get a diagnosis from the clinician. I think that shows where the preferences are of patients.
And is that initially, when they turn up, because they are sort of concerned or anxious about the problem that they have, and they want sort of that reassurance that goes along with that, it'd be interesting to see if once pain and function start to improve, how many of them are then, concerned about sort of a diagnosis. And again, I don't think this is information that we really have sort of a great insight to. So
I think there's a lot of assumption out there about this topic, diagnosis, and what patients think about diagnosis. And I found it a little bit disappointing in the last paper I read about patient expectations. It was about Louis Gifford's postulations or his statements, and they wanted to evaluate these statements in a qualitative study. Unfortunately, they did not dig really deep. So they didn't ask deeper. So what do you think about, what exactly do I want to know about what's wrong with you? Do you really need a diagnosis? What kind of diagnosis? And I think there's still a lot of research to do in this. But
I think so too. And, and then of course we have to balance the words we're using, and, sort of many of us have, try not to use those words which may create fear and anxiety, which relate to structure, and particularly because many people will go home and start to Google that, and they'll see all these big red bulging discs and inflamed facet joints and so we don't want to add to their anxiety and worry, so we do have to be really careful about what words we use, for sure.
But on the other hand, we also should be aware that not only talking about biomedical stuff that can produce some issues, but also talking about the psychosocial stuff with patients. Because I think it was also the Camper study who showed that just half of the patients were actually interested in talk of issues of their life with us as clinicians. And it can happen very fast that the patient thinks, oh, this guy thinks it's all in my head. So that's the common, currently that's a common criticism when we talk about psychosocial approaches with this.
So I think it cuts both ways. I think either way, whatever approach we're kind of using with the patients and chatting, we need to be careful what we say and what impression that the patient is getting from the kind of the words and the perspective we're kind of using. Yeah.
Okay. Yeah. So actually, do anatomy and pathology matter? Yes, to some extent they do. Of course, we don't ignore them, but we can't build our management system on that. Would you agree on that?
Absolutely, I'd agree.
Okay, Richard, it was great chatting to you, and see you next time.
See you for now.
Bye.
Bye.
Bye, folks.